Good afternoon, everybody. I'd like to welcome everyone to Azalea Health's educational seminar on the Rural Health Clinic billing updates. They are effective, as you know, tomorrow, April 1st. My name is Terry Soroki, and I will be your moderator today. I'd like to start out with some housekeeping details and let you know that this webinar will be recorded and made available to you, along with any of our slides, any questions and answers that we cover, as well as any handouts. Please know that we will reserve 15 to 20 minutes at the end of the webinar to answer any questions you may have. You can submit your questions at any time via the chat box in the lower right-hand corner of your screen. Speaking of that, you will notice in the lower right-hand portion of your screen there are 3 handouts for reference. If you need to blow out the box, you would want to click on the plus button that shows handouts 3 of 5. That's where you will find 3 PDFs that you can reference, and we will actually talk about today. Please feel free to download them now or save for later when it's more convenient. First off, we thank you for taking time out of your busy schedules to spend this hour with us. As you know, this is an ever-changing and very busy time in the healthcare industry, and especially for you in the rural health community, and we do appreciate your participation. We will definitely make this next 45 minutes or so well worth your while. Today, we are excited to share our expertise and knowledge on rural health billing updates, best practices to avoid denials, and questions to ask moving forward. And again, as you know, these updates are effective tomorrow, Friday, April 1st. Today we have some of Azalea's team to guide you through the pending RHC billing updates. First off, Chris Carlos has been a regional director with us for several years. Chris is an advocate for the success of the rural health community and is also heavily involved with all your conferences and rural health events. Chris will be taking us through an overview of Azalea's expertise with the rural health community. Next, we have Ms. Helen Williams, who is Azalea's rural health billing consultant. Helen has over 25 years in healthcare financial management and billing and coding in rural practices, clinics, and hospitals. She also provides insight and guidance in credentialing and in working with the rural health community. And last but not least, we have Doug Swords. Doug is the co-founder and vice president of Revenue Cycle Management here at Azalea Health. Doug brings plenty of healthcare industry experience to the table, especially in revenue cycle management and performance. Doug will help you to determine any questions you need answered from your current practice management software provider. So here's what we'll all learn today. First, we're going to start off with the company overview. Chris will reveal and review Azalea's experience with your rural health community. We'll next have Helen give an overview of what's changing effective tomorrow in the rural health billing. Helen will also go over some best practices that you need to know for moving forward. We'll also review some real-life examples. And then Doug will end the seminar with some questions that you'll want to ask your current software provider. And again, as I noted, we will have time at the end for your questions. So without further ado, I'd like to let Chris give you a bit of background about our involvement with your rural health community.
Thank you for the introduction, Terry. Good afternoon to our attendees on the East Coast, and good morning to everybody else. Thank you all for joining us today. We're excited to have you all with us, and we would like to take a brief moment to just introduce Azalea Health. Azalea Health was founded in 2008 in rural Georgia, and today we are a leading provider of fully integrated technology-enabled healthcare solutions and managed services for rural hospitals and clinics. With the foundation rooted in rural communities and over 50 years of experience working in rural and community health systems, Azalea Health is an invaluable source of knowledge and expertise for rural providers and health systems. Azalea works with more than 30 rural hospitals and clinics, providing a range of services which include consulting and assistance in obtaining RHC certification and compiling policies, regulatory compliance and guidance, implementation of policies and procedures, optimization of in-house workflow, coaching for unique RHC billing procedures, and much more. We've been working very closely with our clients over the last month to ensure they're confident and prepared for the April 1st billing updates, and we saw a great opportunity to share Azalea Health's experience and knowledge with the rural community as a whole. After today's webinar, you'll be educated and prepared to confidently manage the April 1st update. We thank you again for the time and the opportunity to share our experience and knowledge, and we encourage you to reach out to Azalea for any guidance and assistance in the future.
Okay, folks, now we'll have Ms. Helen Williams go through an overview of what's changing effective tomorrow. Helen?
Thank you, Terry. In January of this year, CMS mandated changes to our rural health clinic billing format for all of our claims with dates of service on or after April the 1st. Please note that the information we present today is information that is current now. However, changes and revisions may still occur. I would urge you to sign up for the CMS's Rural Health Clinic website to receive emails regarding those updates and changes as they occur. As of today, the regulations change 4 major billing issues in our billing format. We wanted to take a look at those individually, so since they affect many things: our accounts receivable, our claims format, the type of visits that qualify for an encounter. The 4 major RHC billing changes are additions of revenue and HCPCS codes, separate line items, unbalanced claim totals, defining an RHC visit. Remember that these changes are effective tomorrow, April the 1st, and they will only affect your Medicare claims. The first of these changes is the addition of revenue and HCPCS codes to all services provided at the patient's visit or encounter to our clinic. Important to note again that this will only affect claims with the date of service of April 1st and forward. All unbilled claims with prior dates of service will have to be submitted in the same format that we're currently using. The new method of billing requires that all charges and services be added together on line 1 with the revenue code, but in addition, the charges for all other ancillary services performed on that date or that particular encounter or visit will also need to be listed on consecutive lines of the UB with their appropriate revenue codes. Just to clarify, line 1 of the claim will not change from our current way of billing, but you will add additional line items for all other services rendered below line 1. Remember to exclude preventative care services. Same as before, they will not roll up or bundle into the total and be reported on line 1. Okay, we've covered changes from 1 and 2, so let's talk about the change number 3, the unbalanced bill. That may be not the appropriate wording for that, but in the past we've always been taught that our claims go out the door and they total up. Line 1 of our UB claim for rural health clinics and the total charges have always been the same. With this particular change, when all charges are rolled up into line 1 with a total reflecting all services and reported separately on additional claim lines, and then we add totals, we have an unbalanced claim, as line 1 no longer equals the total charges on our bill. You'll want to use line 1 to collect any patient copays at the time of service so as not to overcharge them for that service. Why not? Why do the claim balances not total? As we talked about before, the fact that we're bundling everything into line 1, then we're listing them subsequently below on all the line items, we're actually calculating our ancillary services twice. The side effects of that unbalanced claim, as we talked about earlier, are problems with the accounts receivable. Surely you see that from here. Our total charges will now be increased. They'll not be accurate services because we'll have things counted twice. We'll also inflate our adjustments by having to remove those adjustments when the remittance advice comes back with payment. So you'll need to be very careful about your reports that you run, and when you report your revenue and your charges for the month to your providers. Let's talk about number 4, defining a rural health clinic qualifying visit. A face-to-face encounter with a provider that is medically necessary is the definition that we have for an encounter in our rural health clinic. It could be a mental health exam, it could be a preventative exam, it could be a nursing home visit. They're just a few of the examples. There are many types of visits that we could have. You'll find a handout that we've provided containing a complete list of qualifying visits with today's presentation. I would suggest that you print that down and take that to your providers just to review to make sure that there aren't places that you're missing revenue in your practice that truly are an encounter. Some medical services have been added to this new qualifying list, and they will be effective tomorrow on April the 1st. However, the billing for these services must be held until October the 1st before payment will be released for them. Definitely look for updates on the RHC page for the new information concerning these new visits. So let's recap the things that we've gone over today. So as a quick recap of the 4 major changes we've talked about affecting RHC billing beginning tomorrow is the addition of revenue codes assigned to all of our HCPCS codes, separate line items for all ancillary services, and roll up or bundled line 1 total not being the same as our total claim, and then RHC qualifying visit list being expanded. Let's review some of the examples and how the new charges would look in the format on our UB. Example 1, our patient had a visit for $150 and a lab draw for venipuncture of $20. So let's chart that on the UB and see exactly how it will look. Okay, the first line item will begin with our revenue code, which we've always done in the past, the 0521, with a description of evaluation and management, our CPT or HCPCS code, 99212, and then our date of service, which is March 18, 2016. We'll have 1 unit, and our total charge is $170. That's no different than the way that we're currently reporting it. We're rolling everything into line 1, so that looks real familiar to us. Our second line is our venipuncture, the 0300 revenue code with the actual HCPCS code associated with it, the date of service, 1 unit for a charge of $20. So we've now separated that out. We've included it in line 1, but we've also listed separately on line 2, therefore increasing our total to $190. So the actual patient collection or the patient copay or deductible would still remain just from the $170 on line 1. Okay, example 2, a little bit more complicated. So this time we have to pay close attention because it's even a little tricky. The patient came in for a visit for $150. They had a lab draw or venipuncture for $20 and an initial preventative physical exam for $50. So let's chart that on the UB. Again, we have the first line item is the 0521 revenue code. We have the E&M code, and then we have the total charge for 1 unit of $170. We've rolled together the office visit and the venipuncture code. We have not rolled the IPPE exam because remember, preventative visits are always excluded from rolling up, and that remains the same. So the next line item would be the 0521, the preventative exam with the HCPCS code and the $50. So we'll chart that line on the claim. Third line, you'll notice we have the new revenue code, the 0300 for the venipuncture. will have the CPT code, 1 unit, and $20. So that $20 again is already included in our first line item for an E&M of $150, making it $170. Our total claim, though, is $240 because we've added all line items. However, once again, we've not rolled up the preventative exam. That remains independent and stands on its own. Revenue codes represent the appropriate revenue code for drugs and administration. There is a list of revenue codes that are available. These are new to us, even though they've been used on the hospital side, non-hospital patient billing for outpatient hospital billing for quite some time. In the rural health clinic, we've always known 0521. That's pretty much been a standard for us. Now we need to use the expanded list. I have given you the site where you can go to find those codes, to print them down so that you'll have them ready and available for you to use. Thank you, Terry.
Okay, folks, I hope that was informative to you. Now we're going to have Doug Swords go over some questions that you may want to ask your current PM software provider. Doug?
Hey guys, yes, so there's definitely the coding aspect, which Helen just went over, and familiarizing yourself with that rule. But then if that's not enough, you need to also be considering how is your software going to handle the coding and the UB claim submission under the new rules. So I've come up with a list of 4 kind of questions you want to ask your software vendors between now and when you start billing these new claims out with the new formats or the new rules. So the first one is revenue codes. So Helen just went over now, you're going to have to start sending multiple lines of code information on your UB04s, and each one of them has to have a revenue code. So CPTs and HCPCS that you previously were rolling up or bundling are now going to have to be listed with the appropriate revenue code on the UB. So there's a good chance that you don't have those revenue codes loaded in your software right now because you're not having to use them. Or maybe you are for your Medicaid claims, but there's a good chance that a lot of your minor procedures and some of the other things that you always have bundled before don't have a revenue code loaded with them. So what I would recommend is go into your fee schedule, and there should be a place where for each CPT HCPCS you can assign a revenue code to it. So that way when you put that code on a claim or an encounter, it will go out on the UB correctly. I would start by, you could take that qualifying visit list. Now you may not do all of those services on that list, and then I would run some sort of analysis report in Azalea, it's called a practice analysis, and go back maybe 6 months to a year and get all the CPT codes that you have billed in the last year and make sure that you have a revenue code associated with each one of those in your fee schedule, because those will be your most commonly used. So that's narrow it down too. So if you've got some hospital rounds or things that don't normally go to Part A on your report, make sure you don't have to worry about those. But you do want to make sure that you will reject if they go out on a UB with no revenue codes on the line item. They'll reject when they get to either the payer or the clearinghouse. So that's one. Number 2, does your software have any pre-designated bundling or roll-up rules pre-programmed in it? And if so, how do we undo those, especially if it's tied to Medicare? Because again, this rule only applies to Medicare claims, not Medicare Advantage, not Medicaid. So I have seen systems where you identify at the claim level the principal procedure and then everything rolls up into it. And it's nice and tidy, but now that actually rule is going to work against you because you are not wanting to do it that way for Medicare, or maybe you are wanting to keep it that way for other payers but not Medicare. So find out where those rules can you control them, can you access them and change them, or can your vendor help you with that? Because you're going to need to undo any bundling or roll-up rules that you have in place currently for Medicare. Number 3, let's see. You've got everything in the software. We got our revenue codes loaded, and where we know, okay, are our rules going to help us or hurt us as far as what's being bundled and what's not? But then let's make sure the outbound claim file that you're sending is sending that HCPCS code now, and it's not leaving it blank. So, and the reason I say this is I know some software systems are designed to either not send the CPT or HCPCS, or or suppress it somehow because if the payer didn't want to see it before, maybe all they cared about was the revenue code, you may not be sending it, even though maybe you see it in your software. It may not be going on the outbound claim file. Another thing to check is your clearinghouse picking it up. So you're going to want to probably, if you can, send a test file to them. Maybe reach out to your clearinghouse or your software vendor and confirm, do you see the CPT HCPCS on my UB when I send my electronic claim? Are you getting it on your end at the clearinghouse? Just to make sure it's not being suppressed or that the clearinghouse is not also ignoring it. Sometimes the clearinghouse has mapping rules for your claims, and they may be skipping that box because it wasn't needed before, or skipping that loop segment because it wasn't needed before. So you're going to want to make sure that if you're sending, A, that you're sending it out, that it's making it on your outbound file, and B, that the clearinghouse is getting it, or whatever mechanism you're using to send your claim. So that's going to be important. And then also on the back end, something to keep in mind is when you go to post your payment. So you're going to have more write-offs and more adjustments that you're going to have to do now. And so whether you post everything manually, that means your payment posters are going to have to be aware that when they post, that they're going to have to write those extra line items off that are being rolled but reported separately on the UB. So that's important. Otherwise, they will end up on your aging reports and something that you'll have to go back and clean up later. But the big thing is, do you post remits? And if you do, you're going to want to be ready for that first one that gets auto-posted and to see how it handles those extra line items. Is it writing them off? Is it skipping them? If it's not writing them off, you're going to have to know to go in behind it and write those other line items off. If you don't stay on top of it, it could mess up your aging, and it could increase your aging if you aren't diligent about getting those written off. You may consider depending on who your software vendor is, if they can control the auto posting program, try to come up with a way to get those written off through the auto poster. You may not want it to do that. You may want to control it yourself, make sure that nothing goes wrong. But either way, you are going to have to remember on the back end to go in and write those line items off when they come back in, because they're not payable, even though you have to report them separately. And Helen, correct me if I'm wrong, but I'm pretty sure that you can't send these claims out. You couldn't send it out with a zero. You have to send it out with your fee schedule amount. So then you will have to turn around and write that off later. And so making sure that either your payment poster or your auto posting program accommodates for that. And if it doesn't accommodate for it, that you know to go back in there and pick it up. And that's it.
Thanks, Doug. I appreciate that. Moving on. Now we'll spend some time answering your questions about the pending rural health billing updates. Please use the chat box on your screen in the lower right-hand corner to forward those questions to us. Please also know that if your questions are more specific, we would be very happy to follow up with you one-on-one offline. As you can see on this slide, there is an email address at info@azaleahealth.com that you should send us any additional questions or inquiries for assistance or information. So let's give everybody a couple seconds to think about some real-life examples they might want to ask. And let's see. Let's start out with this one. I think this one might be for you, Ms. Helen. What total will I use to collect my patient copay?
That's a very good one, Terry. Yes, and that would be line 1. You'd want to make sure that you only collect it on line 1, because line 2 would be your preventative exams. And of course, as we know, patients should not pay copay or deductible on that. And so you would collect your percentage and your deductible on line 1 of the charges so as not to overcharge them.
Okay, we have a few more here. Let's see. Here's one here. If a patient is seen in the morning for a sore throat and treated, but then returns later that day after injuring her ankle from a fall, can I bill 2 visits for payment? Helen?
Yes. Yes, you can. You may bill both of those days because they're for unrelated illnesses or unrelated diagnosis or reasons for the visit. You would bill the first visit in the morning as your regular medical visit, bill the second visit in the afternoon. The only difference is you would add modifier 59 to show that it's a distinct and separate service.
Okay. Thank you, Helen. Let's see. Here we have one from someone here on the webinar. If they have a qualifying visit and a procedure, we would not have to hold the claim until October, correct?
The procedure for till October 1st, if you hold you will not be able to receive payment for that. So if you roll it up, so yes, you will have to hold that. Doug, you want to answer that?
Yeah, to be specific, it used to be if you did a minor procedure on a date of service and there was no E&M to bundle it into, they were originally going to say you couldn't bill that as a qualifying visit. Now they're saying that you can. That's why on that qualifying visit download that we have attached, that those items are in red, is because they just added them not too long ago. I think on the 24th they've decided to let you bill for and get paid for those particular minor procedures at your per diem rate, even if there's no office visit or 99213 type code to bundle it into. But for whatever reason, which they don't state, they say if you do have a claim like that, that's for a minor procedure only with no E&M, that you will have to wait until October 1st to bill and get paid for that. I don't think that's going to happen a lot. Most of your clinic visits will have an E&M code with the minor procedure code. But if you do happen to have a minor procedure that takes place on a date of service with no E&M to bundle it into, and it's on this list as one of the red minor procedure HCPCS or CPT codes, then you will have to hold that claim until October 1st. And they don't say why that is, but at least they're saying that now you can get paid for that as a standalone minor procedure without having to bundle it somewhere.
And Doug, this is Helen again. I do think that we will see more information come down on that very shortly, because that actual change in list just came down in the last week or two. So that's why I wanted us to make sure that we were logged into our Rural Health Clinic website to receive the emails and updates, because I think we will get more information very shortly on that.
Okay, here's another question. Can you charge an office visit and an IPP exam on the same date of service? Hey, Doug, is that something you can address?
Repeat the question one more time.
Can you charge an office visit and IPP exam on the same date of service?
Yes, so that goes back to the qualifying visit list. I believe the IPP is the Welcome to Medicare exam, and if you have two visits, it's the same principle as a wellness and a sick on the same date of service. You would be able to bill for and get paid for those on the same date of service.
Another question would be, would this be double billing since it has, oh, this is in regards to one of the examples, but I think the venipuncture, would this be double billing since it has the venipuncture added twice?
No, in the past, that's what we've always been taught, that would be the regulation. Once we charge the venipuncture, then we add it into line 1, we would see that as a double billing. But this way it's not. This is the actual way that they want us to break out the separate and ancillary charges. So you won't be paid for that twice. There'll be, as Doug spoke of, in reference to an adjustment code, there'll be a specific adjustment code that comes through to write off the second venipuncture where it's unbundled, and then another adjustment code that will take it out of line 1. So that'll be pretty clear on the EOB.
Let's see here. Can anyone answer, this is a good question, does anyone have an answer to why these changes have been made by CMS? Do we have the expertise on the phone to answer that?
I don't have it. I have my speculations, but I don't have an answer to that one. I will tell you, I sat on a CMS call, and we talked about the unbalanced billing and some of the adjustments and the things it would do to our AR, and the fact that many of our accounting systems, we pull daily reports with charges. So how do we get our true charges for that day's productivity? And CMS told us that they would take it back, all of our concerns. I'm not sure to whom, but they said that they would take it back and take it into consideration. But they did assure us that the April 1st changes would go forth. Doug, do you have any comments on that one?
I have speculations just like you. I think they're just trying to, my speculation is they're trying to get more transparency on the claim side, so that way when they're looking at cost reporting data, they could do easier reconciliations of the data being reported on reports versus what's being billed on claims.
Okay, thank you, you two. Here's a comment. We were told in an earlier seminar this week with Medicare reps that we could put 0.01 in the amount line, and that this would help with inflated AR. Does anyone have any speculation on or comment on that?
The Medicare article, the MLN Matters article, if you pull that from the downloads, they instruct to put the full fee amount. Now, I don't know if ultimately they'll say they really don't care, you know, a penny or the full fee amount, but the article from Medicare, the release from Medicare, states to put the full, and that's what I would advise until they say specifically that you can send it with 1 penny and documented in writing.
Correct. That's what we were told when that question was asked on the call. We were told to put the regular fee schedule also, Doug. I know in the past we were able to use the 0.1 cent on a claim, but they told us this time that the same as the Medlorn article states, that we would use our fee schedule.
Okay, thank you. Are NDC codes required, and where should they be located?
Helen, I don't think they're going to require NDC codes, even though they're having to report the injectables on the UBs now. There's nothing in the documentation that states that NDCs would be required.
I would agree. I've not seen that anywhere. And I think by using the revenue code, you have the 2 specific revenue codes, or actually there's more than 2. There's a variety of them that you can use for pharmacy. So I think that's going to give them the information they need. I've not seen anything that referred to NDC codes.
Okay. Are we sure that these changes do not apply to the Medicare Advantage plan?
I guess that kind of depends on where you are, but I know in the state of Georgia we have not had a response from, we've asked that question of the Medicare Advantage plans, and we have not been given any information to say to make the changes. Nor have we heard back from Medicaid in Georgia. I know many of you are from different states. I would say check with your local MAC just to make sure, but or with your managed care plans, but we've not heard anything back in Georgia to indicate that they would.
Okay. Another question, how will we be filing secondary claims when we have to wait 6 months to file the red qualifying HCPCS codes when we have to file T19 in 90 days?
I don't think the rule is going to change much on that, Helen. Do you have any input on that? That's actually a very good question. I don't think that would change the current time limit.
Yeah. I don't think they're going to change either. I know that we were concerned when this document came down and we started discussions with the changes with CMS. We were concerned about the secondaries, and we were assured on the call from CMS that that the secondaries could handle the claims. There wouldn't be a problem with the claims. So I don't think anything's going to change. I'm like you. I'm not extremely convinced that they're going to go through as smoothly, but I think all we can do at this point is hope that that does happen.
Okay. Another one would be, let's see here, for the qualifying visit that cannot be paid until October, the document states we should not bill until October. Can we bill it and can we bill and Medicare will hold and pay in October, or do we have to wait until October to send the actual claim?
I think the instruction reads to wait and not file it till October, but I don't think it would hurt for you to try to file it before that, but I would be prepared to file it again after October 1st if it doesn't process.
Helen, anything else to add to that, or is that pretty complete response?
No, that's it.
Okay. Another one, if you only have E&M, do you have to wait until October? Oh, this may be around the same thing. Are all claims held, or only those with the codes in red on the qualifying visit list?
That's right. Only the ones in red would have to be held. But that's only if the codes in red do not have anything to roll it into or to bundle it into. If you have an E&M with one of those minor procedure codes, you could go ahead and bill that out right now. It's only when you have a standalone minor procedure. So a patient walks in, maybe they were seen and evaluated a week ago, and the doctor says, well, come back and I'll cut that lesion off, in 3 days. And they come in 3 days later and they don't get evaluated again. They just come in, they go straight to the room and get the lesion cut off and they leave. In that situation, there's no evaluation to bill, just the lesion removal. And so that's the situation on the lesion removal visit. Since there's no E&M to tie it into, you could bill for that as a standalone on October 1st and get it paid.
Okay.
Unless you wanted to roll it back into the E&M from the earlier visit. I don't know. I think there's a rule that says you might get to do that. Helen, you might be more familiar with that. If it's within a 30-day period, that whole rule with the minor procedures and rolling it back to an E&M if it's related within 30 days.
Right. I have not seen anything that changes that rule. I haven't seen anything that blesses it either, Doug. So I'm assuming that we can continue to do that until such time that we get clearer directions on it.
Yeah.
Okay, another question here. I spoke to Medicare yesterday, and they told, excuse me, and they told me it was my choice if I billed the new listing of procedures to Part A or Part B. Does anyone have any comment on that? Should they go with what Medicare recommends?
You could go with Medicare. I would. Yeah, because normally if it's an RHC claim and it's performed during RHC hours, it would be Part A. So, but if Medicare is telling you it's okay to do it to Part B, then I would follow Medicare's advice.
Thank you, Helen. Will the claims deny for missing modifiers? So if the claims are missing any modifiers, will they be kicked back? The answer is yes. Okay. Let's see here. We currently bill a global fracture charge minus $1. Then for each additional follow-up, we bill 99024 at 0.01. What will be the correct way to bill post-op visits going forward?
Doug, unless you have the answer to that one, I'm going to have to check on hers because I know there is something new about the global surgical period, and I'm not real sure about that one. But Terry, if you'll forward me her email, I'll be glad to research that and send her the documentation back.
Yes, and that's just to remind everybody, we are actually going to send out a full list, a spreadsheet that will show all the questions that have been asked by the audience today and our panelists' responses so that everybody gets all this information in writing. Okay. This might be a little repetitive, but so are you saying all claims, either with or without the red codes, have to be held? So no RHC claims will be able to go now?
No, it's only the situation where the red code is the only code on the UB. Would you hold it? I don't know if that could make it any more simple than that. Helen, I don't know if that is the most simplified way. If the only thing on your UB is that red code, then you would have to hold it. If you have something else to go with that red code, like an E&M code, then you could go ahead and bill it now, which will be 98 point whatever % of your claims will be fileable on April 1st. It will be a very small amount that you would ever have to hold until October.
Yes, I would agree.
Okay. Let's see. We are a physician-based RHC attached to a hospital. Will we now have to put on the J codes when before April 1 we did not?
Yes.
That is correct.
That is correct.
Okay. And a couple of others here include when we send a patient's bill for the balance, they are the ones who are going to be confused. We configure workaround adjustment codes to remove the bundled line 1, but the patient will still see the total billed on line 1. Is there a way to get around that or make it clear?
No, and that's going to take a lot of training and with your front office staff and with your billing staff, because that's one of my biggest concerns with this is suddenly the patient's going to think that we've increased our fee schedule. An office visit that in the past was $100, now we may be charging them for $150. So other than education to the patients, I do not know, and that was a concern that we took back to log with CMS.
That makes sense.
Unless, Doug, do you know of any way that they could do that? Because the Medicare explanation is going to come out with the total charge.
No, I don't know of a better way. They haven't really given us a ton of information, so I think we're going to find out some more stuff after the 1st.
I would agree with that. I think there'll be a lot more information that comes down.
There's one question here about where do we get the list of the red codes, but I believe that's one of our handouts, the revenue code handouts. And again, folks, we'll also email that to you in case you didn't get a chance to download it from the handout section in the lower right-hand corner of your screen. There's just one or two more here. Would you not advise until Medicare provides in writing that RHCs can bill outside Medicare A, UB to Medicare B? For the person who said they were informed we could bill, oh, she was referring to another, did she get something from them in writing?
Right, yeah, that would be important.
I definitely would before I just went outside, particularly if you don't have carved out hours in your RHC. If your total hours of operation are designed to be RHC hours, I would want it in writing.
And another question here, will claims be edited and denied through local medical policies?
Repeat the question one more time.
Will claims be edited and denied through local medical policies?
Like local coverage determinations?
That's what I would assume, Doug. We might, yes, exactly. That's what the attendee has clarified. It's exactly what you said, Doug.
Well, I think the local coverage determinations would still apply. I'm not sure if they apply to Part A. Do they, Helen, or
I was going to say
Part B only?
That's a good question. I'll tell you what, Terry, let me try to get an answer from Medicare on that one and go back to her, just so I can give her an accurate answer. I'm like, Doug, I don't think it will be either.
Okay, yes.
But if they're billing for minor procedures and the minor procedure has an LCD, it could be,
Yeah.
there is an LCD in Georgia for lesion removal, so It very well could be.
Yeah, it could. So let's get back with her, Terry, just to make sure we give her accurate information.
Okay, sure. Yeah, I've noted that here for that attendee. Someone else here asked if we're going to email a copy of the webinar that shows the examples of the billing. Yes, for sure. Again, we will send you not only a video recording of this entire presentation, a PDF of all the PowerPoint slides we used, a listing of the questions and answers that we're going through right now, as well as the 3 handouts. So all of that will come to you probably before the end of tomorrow, if not later on today. And another question, and I think we could probably dig this up, Helen. Someone also asks if we can also send them a sample of the new EOB.
I have not seen one of the new one yet. I've only seen the adjustment codes and some of the Medicare emails and information coming back and forward. But Terry, if you take her address down, I'll try to see if I can find one from one of the clinics that may get one back a lot sooner, or see if we can get one from Medicare. But I've not seen one. Have you, Doug? I've not seen an example of the EOB.
No, it's like you said, they on the MLN article, they've given us the remark code and the adjustment group and reason code that they will be sending on the remit, but not a sample of what it would look like. Like a CO97 is your adjustment group and reason code, and then I can't remember what the remark code was. It's M115 or something like that. But it's on that article. If you read towards the bottom, I think it tells you exactly how it's going to be listed.
When they were explaining this to us, it sounded like they were going to be in separate columns on the EOB, that the 2 new adjustment codes would be pulled out separately. But I've not seen one either. But we'll just keep our eye out for that.
Okay, and I think there's probably just one more. If anyone wants to get their question in, now would be the time before we end this. I think we already answered that about NDC codes. Are they required and where should they be located? Did we do that one, Helen? NDC. Right.
Yeah, we did that one.
Okay, and the only other one would be, let's see. Oh, one person here is, and I think this is in reference to your example, Helen. This person is a little confused. When you say rolled over, does this mean that all charges are still rolled into the E&M charge, but each individual ancillary still has to be listed separately?
Yes, that is correct.
Okay.
With the
exception of preventative medicine codes.
Okay. Okay, that's good. And let's see, I think we're going to have to hit our final one here. How can we be sure we have the correct revenue code or the correct type of injection? The list of revenue codes is not clear. For example, 0636 is the revenue code for drugs requiring detailed coding. Would that code cover a Kenlog injection?
Doug, I might should let you. Do you have, if Kenlog injection has its own specific J code, then yes, it would. But if it has an unspecified code, no, you would use the 0250.
Yes, I think most of the ones they would use in the office will have a specific J code, and I'm pretty sure they have a 636 revenue code.
Right. I'm just not sure about Kenlog if it has its own, but if it does, it would be the way, yes.
Okay, and 2 more, and then we're done here. When we call Medicare and Medicaid or Medicaid plans, we are getting info stating no information about new changes in RHC billing.
Not surprised.
Surprise.
April Fools.
Yeah, wouldn't that be nice?
So what's up with that, Helen?
I don't have an answer for that one because I'm getting the same thing when we call Georgia Medicaid. Since this started in January when the changes, we started talking about the changes, we've been trying to get a decision from Georgia Medicaid, and we've not gotten any information either, and they don't seem to know what the changes are. So The only thing I can tell you is watch, which is what I've been doing, watch the banner messages on your Medicaid website just to see if something comes up with a change. I would think that they would send us an email blast letting us know what they were going to do if they were going to do anything differently.
Yeah, we can certainly post that on our rural health page on our website, folks. So if that's something that you want to check out, we'd be happy to do that. And I think if I'm not mistaken, Helen, they could sign up for updates on the RHC webpage. Is that where they would also get updates?
They would get updates from CMS on the CMS RHC
part.
web.
Okay.
But the Medicaid would have their own banner messages on their website.
Okay. And folks, we appreciate your patience. Here's the final question. Since these changes are mandated by CMS, is it acceptable for a software vendor to charge for a separate module to accommodate these changes? Doug, I think that's yours.
I don't see where a separate module would be necessary. It's just the changing on how you process the CPT data within the claim that's already in the software. And the part about auto posting should be something that you're already using, not a separate module. And so I don't think so. No, it's just making sure that the software can accommodate the rule changes, but it all should be within the realm of what you're already using in the software.
Okay. Okay, folks, let me just double check if there's any more questions here. I think we've pretty much covered a lot of different topics, and I hope everyone got something out of this. So I just want to say on behalf of the entire Azalea Health team, and especially Chris, Helen, and Doug, I sincerely thank you for attending and participating in our educational webinar today. Again, the webinar will be made available to you not only through our website, but we'll email that, the slides, the handouts, and all of these questions and answers we went over today to you as well. Again, if you need any further assistance, have some questions once you hang up, please use the email address info@azaleahealth.com that you see on your screen right in front of you if you need Azalea or anybody here, our panelists, to help you out in the future. Just know that we're happy to help in any way. We wish everyone a great day, and we thank you again for your time. Bye-bye, everybody.
Thank you all. Bye-bye.